Hello again, all, and welcome to the Science of Childhood Cancer lecture series hosted by the St. Jude Comprehensive Cancer Center. I'm Melissa Hudson, co-leader of the Cancer Control and Survivorship Program in the Cancer Center. And on behalf of myself and my co-program leader, Les Robison, we welcome you to the 7th week of this 15-week series. This series was initiated during this time of COVID and has engaged more than 3,000 registrants as of this week and attendees from all over the world. It's my pleasure today to welcome Dr. Kevin Kroll from the Department of Epidemiology and Cancer Control and Survivorship Program here at St. Jude. Before I formally introduce Dr. Kroll, I'd like to briefly mention that you can submit questions at any time during the talk using the chat function and sending questions to all panelists, or if needed by emailing them to the email noted on the slide, socc@stjude.org. Note that we will pause about halfway through if there are any questions at that point, and then we'll also leave time for more questions at the end of the hour. Dr. Kroll has kindly offered to stay on for some time after the official close of the event at the top of the hour if anyone would like to stay for further discussion. And now I'm pleased to formally introduce Dr. Kevin Kroll to you, who is a member of the faculty at St. Jude with appointments in the Department of Epidemiology and Cancer Control and Department of Psychology. He also holds an endowed chair in cancer survivorship. Dr. Kroll is a board-certified clinical neuropsychologist with training in cognitive neuroscience, biological psychology, and clinical psychology. His research examines biomarkers of central nervous system integrity and chronic health conditions that impact brain development and function in survivors of leukemia and lymphoma. He has translated findings from his research into innovative randomized clinical trials evaluating neuromodulation and health behaviors to promote healthy brain aging and overall health in long-term survivors. Dr. Kroll is a recipient of numerous research grants from the National Institute of Health and is PI of a T32 grant from the NCI to train postdoctoral fellows in pediatric cancer survivorship research. We are delighted that Dr. Kroll will provide the second survivorship talk in the Science of Childhood Cancer series entitled Cognitive Outcomes of Childhood Cancer, Neurophysiology, Biomarkers, and Intervention. So I'll turn this over to Dr. Kroll. Thank you for your attention.
Thank you, Melissa, for that kind introduction. And I'd like to thank Charlie Roberts and Charles Mulligan for putting this seminar series together. I'm honored to participate in it. So just as a outline here, we're going to start by talking about definitions and descriptions of cognitive outcomes and impairment. What are we really talking about and what is it? Discuss some of the neurophysiological aspects of outcomes. And then at that point, we'll take a break for question and answer. And then we'll get into biomarkers of cognitive outcomes in cancer survivors and explore options and discuss issues related to interventions to address cognitive impairment in the survivors. So let's start by talking about prevalence. Prevalence depends on how you measure cognitive dysfunction and the thresholds that you apply for what you determine to be normal or abnormal. We can see on the graph on the left, this is a study done by NCI that looked at self-reported impairment on population estimates through SEER and found when we look at self-reported impairment and set a threshold at 10% of the general population, we have roughly 24% excess impairment. The graph on the left is a study done at St. Jude, which directly assessed cognitive function on a number of domains and set the threshold at moderate to severe impairment, being 2 to 3 standard deviations below the population norm. And when we look across any type of impairment using that definition and direct assessment, we see a twofold increase in this level of impairment, 50% excess impairment. And part of that is due to the assessment, but also I think when we talk about the onset of a cognitive deficit in a young child and development into adulthood, there's quite a bit of adaptation and adjustment that goes on. And when we ask questions about self-impairment, that often is interpreted in different ways by individuals who grow up with impairment. Another way to look at this is looking at phenotypes. Typically, survivors don't have just one cognitive domain impaired. This is, again, a study from St. Jude using about 3,000 survivors who were directly assessed. And as you can see here, based on this latent class analysis, we have really four groups of individuals that demonstrate impairment profiles or phenotypes. Those that demonstrate global cognitive impairment on multiple measures, those that demonstrate only attention problems, those that demonstrate only memory problems, and those that demonstrate executive function and processing speed problems. You can see the frequency by diagnoses along the bottom, and notice the differential patterns of impairment. Those, for example, those with CNS tumor have 12 to 13% have global cognitive impairment, a pattern that we don't really see in Hodgkin lymphoma, where the deficits tend to be focused either in attention, memory, or executive function. Let's shift now to talk about some of the factors that impact cognitive outcomes. This is a schema that I like to use and consider the multidimensional, multiple factors that impact cognitive brain and cognitive development over time. And you can see we have variables that the child walks in with, neurodevelopmental status, which is not necessarily the same as age, but the developmental functioning of the individual prior to any cancer or treatment. And then we have things that occur during cancer therapy, such as neurosurgery, radiation, exposures that are believed or known to be neurotoxic, reactions that the individual experiences in terms of infections, neurotoxicity, maybe exposures to anesthesia, and then long-term outcomes that impact central nervous system development, chronic health conditions that may interact with that central nervous system, and then interventions that may have occurred in the environment of the child over time. All of these go into the equation of developing cognitive outcomes, and they interact with one another. Looking at specific exposures, this is a study done by Tara Brinkman back in 2016 that looked at cranial radiation exposure in adult survivors of CNS tumor. And you notice that not only dose, but the planning of and mapping of the exposure is important here. For example, we see a dose response effect between those exposed to cranial spinal radiation compared to focal radiation only. But over the years, our ability to move from 2D mapping to 3D mapping demonstrates a improvement in some of the outcomes over time. This is most notable in ongoing studies out of this particular study out of Baylor by Lisa Cahaley, looking at proton beam exposure. We have better control over that mapping and dosimetry. And we see that those individuals exposed to proton beam over time demonstrate relatively better working memory compared to those exposed to photons. Not necessarily the case for processing speed. So we may see improvements in certain abilities, but not necessarily others. We see a similar dose response pattern when we look at chemotherapy exposure. This is a study I published a few years back looking at methotrexate exposure. And we used serum concentrations of high-dose intravenous methotrexate exposure over time. And we see that the increasing doses of methotrexate, regardless of whether you were treated with lower doses in a low-risk pattern or higher doses in a high-risk or standard risk arm, increasing doses are associated with decreasing performance in various cognitive abilities, including cognitive flexibility and verbal fluency. Just to orient you to this graph, these are presented in age-adjusted z-scores. So each one of these are a half standard deviation to a standard deviation below the population norms. But not only does methotrexate or is associated with reduced cognitive function, We see it also associated in a dose response pattern to cortical thickness in these survivors. Here we have thickness of the dorsolateral prefrontal cortex, and again, methotrexate exposure, serum exposure to methotrexate, both left and right hemisphere, thicker cortices with increasing dose of methotrexate over time. And I know we talk about thicker cortices, but this is not always necessarily better when we think about this from a developmental perspective. Cortical thickness is greatest shortly after birth, and due to pruning over time, we have a reduction in cortical thickness with maturation, with increased reliance on connectivity patterns rather than thickness of the cortex. But not only is the cortex impacted, we see this study by Edelman, published in Brain in 2014, that looked at adult survivors of ALL treated either with cranial radiation therapy or chemotherapy alone compared to controls. And looking at volume in the hippocampus as adults, we see a significantly smaller hippocampus, not only in those exposed to cranial radiation therapy, but also those treated with chemotherapy compared to these control groups. This is matching based on age and gender and et cetera. So we see some smaller subcortical volumes into the cortical thickness volume. Cerebellum also seems to be impacted. This study recently accepted by Nick Phillips shows intracranial volume as well as cerebellar volume. And although neither male nor female survivors demonstrate significant differences or smaller intracranial volume, they have relatively smaller cerebellar volume compared to age and sex-matched controls. Why is the cerebellum important in cognitive function? Well, it's part of a neural network that helps to establish the basis for cognitive functions. In this particular case, the cerebellar-thalamic cortical pathway, where the cerebellum communicates with the thalamus and the dorsolateral prefrontal cortex and cuneus to help facilitate executive functions. And this is just one of the nodes in that network. And when we disrupt even a particular node, we can disrupt the overall function of the network. This is most evident in some relatively recent work published by Shelley Kessler in adolescent survivors of leukemia treated only with chemotherapy, where we see mapped on the left side 4 common neural networks: a sensory motor network, executive attention network, the salience network, and the default mode network. Each one of these different dots is a node. The size of the dot is relevant to the contribution to that network. And the color coding represents the connectivity or the network itself. You notice in the leukemia survivors without impairment, we have relatively intact networks across all 4 of these common networks. But in those leukemia survivors, roughly 40% with cognitive impairment, we see loss of an integrated executive function network. This light blue color is not represented here. It's not that the executive function isn't there in these survivors, it's just that it's not an efficient network. It's not developed at the same level with the same integrity as these survivors without impairment. Development of neural networks is important to achieve cognitive function, but it's important to have a well-balanced neural network as well. In these same survivors with cognitive impairment that have underdeveloped executive function network, they seem to have overdeveloped sensory motor networks. The network is relatively too strong for their age. And so we have this desired pattern of connectivity where too little is not good and too much is not good. And this changes with the development of the brain over time. When we have this relatively reduced executive function network, we see that, for example, those individuals with higher activity or higher exposure to methotrexate have this executive function network, which seems to be working more effortfully compared to individuals without or with less exposure. So in this study by Slimfella, published a couple of years ago, we see that this purple color here demonstrates increased activity that is correlated with increased methotrexate exposure. And this is done during a cognitive flexibility test. So basically these areas of the brain, because the network has been underdeveloped, are working harder to achieve the same level of cognitive flexibility compared to other functions and other individuals with reduced exposure. So this network pattern is important to take in mind because it develops and over the lifespan of the individual and goes through a scaffolding process where some networks are built upon other networks, and if we disrupt the connectivity early on, we can disrupt the ultimate outcome of the function. Gears a little bit here and start to talk about some of the physiological aspects and factors that contribute to some of these neurocognitive outcomes outside of the direct neurotoxicity of some of the therapeutic exposures. Start off with sort of general inflammation and infection, looking at a study done by Yin-Ting Chung a couple of years ago here at St. Jude, looking at the development of sepsis. And just to orient you, on the left side here, right side here, we have individual associations where sepsis increases the risk for cognitive function. And on this left side of this graph, we have decreased risk for cognitive function. And then the cognitive functions here mapped out in Z-scores. With the difference in 95th percentile, keeping in mind that a Z-score is roughly a standard deviation. So individuals who have a history of sepsis during their therapy or shortly after their therapy, adjusting for treatment exposures, demonstrate about three-quarters of a standard deviation increased risk for impaired spatial planning, poor inhibitory function, working memory function, et cetera. So sepsis on top of the neurotoxicity increases the risk for these executive function problems, the attention problems, and the processing speed problems. Stroke is also a relatively common outcome in our adult survivors of childhood cancer, more common than community controls and their siblings. And here I'm showing you a graph from a publication by Sabine Mueller a few years back, looking at the increased risk hazard ratio for stroke with increasing cranial radiation dose, showing that a radiation dose of 50 plus gray results in about 11-fold increased risk compared to no radiation at some point in time. And this stroke risk is associated with increased cognitive function. So those individuals without stroke compared to those individuals who have a single stroke or recurrent stroke, demonstrating 2 to 3-fold increased risk for problems in task efficiency and a 2 to 3.5-fold increased risk for problems in memory. Again, adjusting for dose of cranial radiation exposure, chemotherapy exposure, sex, and age. So stroke on top of the risk factors associated with these treatment exposures is important to consider. Seizure history has been identified to be associated with memory problems in our adult survivors, not just those that have CNS cancers, but those without CNS cancers as well. So here you see again age-adjusted z-scores. -1 is one standard deviation below. -1 is one standard deviation below the normative mean. And we see that those CNS exposure, those individuals who have non-CNS cancers, if they have a history of seizure, have half to almost 3/4 of a standard deviation increased or lower performance on measures of learning, short-term and long-term memory. Again, adjusting for doses of cranial radiation and methotrexate and other cancer exposures. We see this same pattern in CNS survivors as well, with increasing deficits in short-term memory, long-term memory in those with seizures compared to those without seizures. Those without seizures continue to have problems associated with the original treatment exposure. But central nervous system chronic conditions are not the only type of chronic conditions associated with neurocognitive outcomes. In this work that I'm doing at St. Jude, looking at long-term outcomes of adult survivors of childhood Hodgkin lymphoma, we see that Hodgkin lymphoma who don't receive cranial radiation or fecal methotrexate, the Hodgkin lymphoma survivors demonstrate increased rates of impairment in attention, processing speed, memory compared to community controls and compared to population norms. And those impairments are associated with the onset of vascular disease, cardiac disease, pulmonary disease, as well as endocrine disease. So these vascular, cardiac, and pulmonary conditions tend to evolve over time. And as a result, the onset of the cognitive deficit may also evolve over time. Sleep is also an important function and chronic condition that is associated with reduced cognitive impairment. This is a study in development by Tara Brinkman looking at the impact of insomnia and fatigue on cognitive outcomes, particularly memory abilities. Compared to individuals with no insomnia, those individuals with insomnia and daytime sleepiness have about a half standard deviation increased half standard deviation reduction in their cognitive performance on measures of learning, short-term memory, and long-term memory. The interesting thing here is that females appear to have a lower threshold for this impact on cognitive function, in that we see insomnia with daytime fatigue impacting both females as well as males, but insomnia without daytime fatigue or sleepiness still impacting females and not males. We've seen this in other samples as well, including adolescent survivors of childhood ALL, where females seem to be more sensitive to the impact of sleep disruption. I've been involved in looking at a different aspect of sleep, that being sleep apnea in our Hodgkin lymphoma survivors. This is a study I'll present at SIOP next month, where we did polysomnography to look at sleep apnea in our long-term survivors of Hodgkin lymphoma compared to community controls. Community controls were recruited that were matched to the survivors on age, sex, race, and body mass index. And here we see that based on polysomnography sleep studies, 2 consecutive sleep studies, 50% of our Hodgkin lymphoma survivors demonstrate clinically significant sleep apnea, compared to 18% of our controls, or roughly fourfold or threefold increased risk. You can see down here the patterns of sleep apnea with almost 43% of those that have sleep apnea being of the severe nature, with apnea-hypopnea indexes of greater than 30. I'm sorry, I keep jumping ahead. So just for those of you that aren't aware, an apnea-hypopnea index is the average number of apnea events per hour. A apnea-hypopnea index of greater than 30 is more than 30 events per hour of sleep throughout the night. Among those survivors who have sleep apnea, you can see, again, roughly 50%. So those 63 survivors with apnea, 61% survivors without apnea. You can see the average hypopnea index, but take a look at these mean oxygen desaturation levels and lowest oxygen desaturation levels. Long periods of time throughout the night that these survivors are basically in a hypoxic state. And this hypoxic state clearly has an impact on cognitive function. We see that in the general population, that obstructive sleep is associated with memory impairment and attention problems, but also increased risk for cardiac disease and heart attack, as well as stroke. In this Hodgkin lymphoma population, which is already at increased risk for cardiac disease due to the thoracic radiation or anthracycline exposures, the added risk of the apnea on top of that could be quite devastating. So I'm getting ready to shift into the biomarker and intervention portion of the presentation, but I think this would be a good time to take questions and
okay, Kevin, there's a few questions that have been posted. One is, deficits are described in excess of population norms, but how impactful are they in the daily life of the survivor? Can you comment on both young and aging adult survivors? What would one expect?
Yes, so the mild impairment, mild deficits, which are, a standard deviation to maybe 2 standard deviations below, are not particularly impactful. It depends on the expectations in the environment. So this is part of the reason why we set our deficit level as moderate to severe. So a deficit, we define a deficit as being at least 2 standard deviations below the population norm, which occurs about in 2% of the population. So we do see that that level of deficits is associated with decreased or increased likelihood to not graduate college. It's associated with increased likelihood to be unemployed. It's associated with increased likelihood to live dependently on someone else. But the practical impact really depends on the expectations and the environment of the individual as well. If this is an individual who is working in business or accounting or in finance, mild to moderate deficits can be quite impactful. If this is an individual who is unemployed and at home most of the time, the deficits may not have a daily impact, but likely contribute to the reason why they're unemployed and at home most of the time.
Okay, another question is, with respect to disruptions of neural networks, are there distinct associations between disruption and type of therapeutic exposure, such as cranial radiation versus methotrexate?
Yes, we are starting to see that. So presented you some brief data to show that cranial radiation exposure impacts hippocampal function and integrity, as well as methotrexate. Methotrexate tends to target, from what we can tell, more of the myelin and white matter, and it's associated with leukoencephalopathy, whereas cranial radiation is often more impactful in those areas of the brain that have a small but rich vessel supply. So microvascular injury is more common in the radiation exposure. But some of the long-term deficits depend on when the treatment occurs. So if the treatment occurs during the ages of 2 to 3, when sensory motor networks are rapidly developing, the same exposure can have a greater impact on sensory motor networks compared to somebody who is treated at 15 to 16 when some of the attention and executive function networks are developing. So we had to take into account the developmental state of the brain at the time of the exposure to fully understand which networks are likely to be impacted. Those that are in rapid development tend to be more sensitive to those that are well established.
Okay, here's another one. Do you only see patients suffer from impaired development, or does cognitive deterioration also occur with treatment exposure?
We are beginning, this is a hot area of research right now, and we are beginning to see that cognitive decline is progressive under certain circumstances. Nick Phillips, who is a former postdoc of mine and is now on the faculty at St. Jude, will have a study coming out this spring that looks at a roughly 15-year follow-up of close to 6,000 or 7,000 cancer survivors, looking at their cognitive function over time. From that study, I think we can see that there are significant groups. There are groups that demonstrate significant decline in memory function and other abilities. So this does appear to be progressive over time. What we're currently trying to tease apart is the progression due to new onset chronic conditions, such as cardiac disease that begins in the 30s and 40s, or is this a accelerated cognitive aging due to DNA damage and other molecular aspects? That is an unknown at this point in time, but I think we have fairly good evidence that the decline increases, the risk for decline increases with age.
Okay, let's try to squeeze in one more. When assessing changes in cognitive function, are there specific time points during therapy and follow-up that you recommend testing patients?
So it depends on the age of the patient and the sensitivity of the measure. So we've looked at, we've done previous studies, and there are many ongoing studies, and the abilities that can be reliably detected within months of diagnoses are things like processing speed. White matter injury due to certain exposures can be detected fairly soon. Whether it progresses and continues or whether there's recovery or not is a big question. So we have evidence, I don't have the time to present it today, that individuals can demonstrate cognitive impairment, things like attention problems at 5 years from diagnoses, as well as attention problems at 30 years from diagnoses. And those attention problems can be due to different things. And so the attention problems are often associated with exposures early on, but may be associated with chronic conditions later. So the stability of certain functions are still being evaluated. And there are just certain things you can't assess in very young children. So, a 2-year-old who was diagnosed with leukemia and treated with neurotoxic exposures, you may be able to detect processing speed problems, but a 2-year-old doesn't have executive function well mapped out. You can't really assess that well. So you need to wait until they reach a developmentally appropriate age to begin to assess them in those cognitive skills.
Okay, we're going to hold off. There's some questions about interventions. I think that'll be better at the top of the hour. So Kevin, why don't you go ahead and resume, and we'll have more time as you complete it.
So let me start by talking about biomarkers, and I'm going to talk just about several studies, both systemic and central biomarkers, and then we'll move into interventions. This is a study done by one of my postdocs a few years back, looking at adrenal function in our leukemia survivors. These survivors were roughly 7 years from diagnosis, so relatively stable in survivorship period. We assayed blood at the time of testing, cognitive testing, to look at adrenal function, and found that some sex differences, really. It's the males, for example. You can see both the males who have low adrenal activity demonstrate increased impairment, increased risk for impairment in sustained attention, and more likely to have impairment in attention variability with low adrenal function. We didn't see that pattern in females, so we start to see some biomarkers are help to explain some variability between some of the sexes that we see in long-term outcomes. I published a study last year looking at growth hormone deficiency in leukemia survivors. These were adult survivors that were roughly 25 years from diagnoses. And we found that survivors had increased frequency of growth hormone deficiency, and that growth hormone deficiency was associated with lower performance on measures of vocabulary, processing speed, flexibility, and fluency. See the dots in red here are those with growth hormone compared to non-growth hormone. And again, age-adjusted Z-scores. -1 is one standard deviation below the population mean or average. In this particular study, it turned out that the growth hormone wasn't informative of mechanisms of the cognitive deficits, but really just a side effect or a function of the radiation exposure. We did some sophisticated statistics to look at mediation models to understand the direct and indirect effects of the cranial radiation on the outcomes. And in almost every case, the direct effect of cranial radiation, the cognitive function, explained the cognitive outcome. The indirect effect through growth hormone deficiency did not explain cognitive function, and the growth hormone deficiency was just another outcome of the cranial radiation that appeared to be independent of the cognitive impairment, at least in these leukemia survivors. We've also looked at, as many people have, inflammatory and oxidative stress markers, and we know that chemotherapy and radiation increases reactive oxygen species and increases peripheral pro-inflammatory cytokines. These can be detected in the blood, and this can lead to DNA damage and disruption in the blood-brain barrier, and some of the cytokines can cross right into the central nervous system to impact cognitive function as well. This was a study we published a couple of years ago looking at inflammation in adolescent survivors of ALL. These were leukemia survivors who were treated with chemotherapy only. Again, looking at age-adjusted Z-scores. Those survivors, and we compared survivors based on the tertiles where their interleukin values fell, C-reactive protein values fell. Whether they were in the top tertile, indicating that they had signs of increased inflammation versus the second and third tertile, lower tertiles. And with interleukin 6, we saw that survivors in that top tertile had poorer performance on measures of cognitive flexibility, organization, reasoning, motor processing, visual processing. Similar patterns with C-reactive protein. We have also looked at C-reactive protein more recently in our Hodgkin lymphoma survivors. Anna Lynn Williams presented this study last year, is working on a manuscript currently. Just to orient you, this is a slightly different slide here that's showing Z-score differences. The average difference between those who have elevated C-reactive protein compared to those with more normal levels of C-reactive protein. And in this adult survivors of Hodgkin lymphoma, with the C-reactive protein collected within days of the cognitive testing, those with elevations on average had 50% lower, or a half standard deviation lower performance on measures of attention, processing speed, and learning cognitive flexibility measures. So those are some of the systemic biomarkers we've looked at. We've also looked at some central nervous system biomarkers, and just to show you a few of them, we've examined tau protein, which is an index of damage, myelin basic protein, which increases in cerebrospinal fluid, often associated with demyelination, nerve growth factor associated with neuronal damage, gliofibrillary acidic protein associated with astrogliosis, and then importantly, chitotriosidase, which is an index of microglial activation, which is often seen in inflammation and injury in the brain. We sampled these CSF samples or CSF fluids at baseline, and then with each intrathecal injection, prior to each intrathecal injection, through induction, consolidation, and reinduction. And this particular graph here showing that we see a large increase in microglial activation or inflammation during consolidation that returns back to a baseline level throughout the reinduction periods. We also saw significant increases in nerve growth factor, increase in tau protein associated with induction and consolidation. And then some of the white matter indices in myelin basic protein and astrogliosis, for example, were elevated even at diagnoses prior to any treatment. I'm not going to present it due to time, but we have associations between these increases in proteins and concentrations of treatment exposures, as well as brain imaging at 7 years later during long-term follow-up to show white matter damage and cognitive impairment. Currently, we have a grant that is looking at mapping the entire proteome in the CSF in childhood cancer survivors, and we're working with Xiaoming Peng at St. Jude in the proteomics lab. So far, we've successfully identified almost 2,500 peptides and almost 500 proteins in samples, are beginning to see changes in proteins over time. But with Xiaoming's liquid chromatography and mass spec process can quantify most of those proteins as well. So looking not only at the presence of the protein, but the change in the protein over time. These survivors are in the process of getting a long-term follow-up in terms of neurocognitive and brain imaging outcomes. So we'll be able to report on those associations shortly. So this is a schema that I like to think about. And it's a little confusing, but I'll walk you through it very quickly. There are multiple pathways to cognitive and brain function, poor cognitive and brain function. These start with treatment exposures and maybe even before treatment with the diagnoses that can impact chemistry in the brain that has direct implications for development of the cortex, white matter, vasculature, resulting inflammation. Some of these other treatments also through increased systemic inflammation may impact cardiac and pulmonary function, endocrine function. Some of this impact is associated with chemoreceptor distribution in the brain. For example, corticosteroids, glucocorticoid receptors are highest in the cerebellum and the hippocampus. And we would expect glucocorticoids, if they're associated with toxicity, to have impacts preferentially in these areas compared to others. We see evidence of cardiac and pulmonary pathology, which leads to hypoxia and potentially sleep apnea, which may be associated with stroke. And so all of this is important to take into account when we start thinking about interventions in outcomes. The treatment of some of the cognitive problems not only have to take into account those multiple pathways, but also recall the phenotypes of impairment. So we're not treating one cognitive deficit, we're treating different cognitive deficits, and even within the same diagnoses, we may have 4 or 5 different groups of individuals with different cognitive patterns that may require different interventions. Excuse me. And we have to take that into account as well as the pathway that is contributing to that cognitive deficit. So let me walk you through quickly just some of the interventions that have been done and some of the things that we're doing as well. Many of us over years have used special education services in school, and this is not really a randomized intervention, obviously, but children require special education to help progress in the school system. Lisa Jacola published a paper from CCSS a few years back that demonstrated that history of special education was associated with a 70 to 80% higher risk for not graduating college. So we know from this and other data that although survivors often need special education, it doesn't tend to normalize function and produce the same results as those that don't require the special education. Psychoactive medications have been used. Methylphenidate, for example, improves attention problems in ALL. Heather Conklin here at St. Jude has demonstrated that in several publications. Donepezil has been demonstrated to improve memory function in CNS tumors. But many patients and parents tend to be somewhat hesitant to use medications after coming off of long chemotherapy protocols. And again, these are targeting specific cognitive abilities. If the individual doesn't have attention problems, methylphenidate may not work. Or if the individual has attention problems, but they're associated with cardiac pathology, we may not want to use methylphenidate, which may exacerbate their cardiac disease. In addition, Yinting Chung had demonstrated through this is another study from CCSS, following up patients that use medications as adolescents to long-term adult outcomes, that use of medications doesn't really normalize function. We still see increased risk of cognitive impairment during adulthood in adolescents who use medications compared to adolescents who didn't use medications. And this is adjusting for the cognitive impairment, level of cognitive impairment that they demonstrated during adolescence. To me, medications is a temporary Band-Aid, but does not normalize brain development and function. Cognitive and education and rehabilitation has been attempted. Bob Butler, several years ago, published a paper looking at intensive individualized cognitive therapy, over 40 hours of individualized one-on-one therapy with children, teaching them cognitive strategies. Basically, what he demonstrated was that after those 40 hours, children demonstrated better learning strategies, but it did not improve attention, memory, or specific cognitive skills. Many people are looking at cognitive training of working memory using things like CogMed or other procedures. This is a study by Heather Conklin that demonstrated that cognitive training with a working memory task does improve function, but it improves function primarily for working memory. And after 40 hours, 40 hours of cognitive training, what we see is that working memory improves. But at this point, there is very little evidence of generalization to other cognitive functions. So if the child only has working memory problems, this may be helpful. Neuromodulation has also been attempted. We do that as part of my research program as well. Neuromodulation, things like neurofeedback, for example, providing feedback to individuals based on their EEG patterns. There's a large study done out of the Netherlands by Michel de Rode, that demonstrated that neurofeedback after intensive efforts was not effective in improving any cognitive function in adult survivors of cancer. We use transcranial direct current stimulation to help enhance cognitive function. Transcranial stimulation, just for those that may not be aware, is the application of low voltage current to the brain. We pass a low voltage current, typically 1 to 2 milliamps current from one electrode to another. The initial studies use just 2 electrodes. Many current studies are using multiple electrodes so that you can regulate the flow of current a little bit better. And the current is designed to help sensitize the neural network underneath the exposure. So we can increase resting membrane thresholds with stimulation and make those areas more likely to engage in function, or we can inhibit resting membrane thresholds to make it less likely to engage in function. So if we know that neural networks and that specific neural networks are either underdeveloped, as in the executive attention network, or overdeveloped, we can stimulate one neural network and make it more likely to function, and inhibit other neural networks and make it less likely to function. And these are studies that we're currently engaged in right now. Based on our pilot data, we demonstrated that in a small pilot study, we can improve both self-reported cognitive function and improve directly assessed cognitive function in as few as 10 sessions. So, roughly the 3 hours versus 40 hours of cognitive training without the transcranial stimulation. And the key point is knowing the neural network and mapping the neural network to facilitate the activity in those areas. So we have a current grant going on, for a year R01 grant that Tara Brinkman and I have that will map this out in a larger population, along with looking at changes not only in cognitive function but neuroimaging functions. Health behaviors are also an important aspect of interventions and have been tried in multiple areas. Alicia Kunin-Batson at the University of Minnesota has a study that is completed looking at healthy lifestyles in young adults, not adult, but childhood ALL survivors. This particular study focuses on children between 4 and 7 years of age and targets parents. So using motivational interviewing with parents to improve the home environment by decreasing sedentary time, increasing active physical choices, improving and enhancing sleep hygiene techniques, and improving healthy eating, we can have an impact on health behaviors early on in these young survivors. Sleep hygiene, we talked about some of the studies with insomnia previously. Tara Brinkman and I have an ongoing R01 looking at trying to improve insomnia and examine its impact on cardiovascular as well as cognitive function. This was based on a pilot study we did at St. Jude using melatonin, which was not effective in improving sleep. But when we look at the data, those individuals who improve in insomnia, regardless of whether they're treated with melatonin or in our control group, had improved cognitive function. And then physical activity is also a area that can have significant benefits for cognitive function. This is a study done by Emily Barlow and Kim Edelstein at Princess Margaret Hospital in Toronto, looking at long-term physical activity over time. So they looked at whether individuals were engaged. It's not a randomized controlled trial, but they looked at whether individuals were engaged in physical activity in a consistent manner over a 15-year gap, or whether they were inconsistent versus no physical activity, really. And they demonstrated that consistent physical activity protects against decline of cognitive function over time. In the no physical activity groups or reduced physical activity groups, demonstrated a reduction in cognitive function over time and consistent engagement in physical activity, both in CNS and non-CNS populations, demonstrated a prevention of that decline. So, and then there's obviously preventative approaches that can be done. Memantine, for example, which is an antioxidant, has been used to help buffer against memory deficits in CNS tumor patients. A study by Brown that was published a few years back from MD Anderson that showed at 6-month follow-up post-radiation exposure, memantine given during radiation exposure led to fewer memory deficits compared to a placebo group. And then we've also looked at educational training to help maintain certain cognitive functions during maintenance of cancer therapy. But really, prevention can involve any of these other behaviors as well. Health behaviors or neuromodulation are some of the cognitive strategies. They've just not been reported as of yet. So to summarize, we're at the top of the hour. So survivors experience elevated risk for cognitive deficits, but not necessarily the same deficits. Even within the same diagnoses and the same exposure, we may see different deficits, and as a result, we need targeted and individualized therapies to help address those deficits, taking into account not only the deficit, but the etiology, because even when the deficit appears similar, the etiology may be quite different, and the pathway that the individual got to that deficit may be quite different. For example, back to attention, for example, attention deficits can be treated with methylphenidate to improve function, but if that individual has attention problems due to cardiovascular pathology, methylphenidate may worsen the outcome. Risk for cognitive deficits continues throughout life. It may change over time based on the health status. Somebody may start with a cognitive impairment due to the neurotoxicity associated with methotrexate. The anthracycline exposure that they also receive may impact the heart after 5 or 10 years and produce other deficits as they age and mature. Imaging and chemical biomarkers can help inform on mechanisms and may help target some of these interventions. And treatment approaches need to be identified. And I've said this several times, but I really want to drive it home. They need to be identified and they need to be based on the etiology and not just the specific deficit identified. With that, everything I do is in support of multiple, numerous collaborations with many, many people. And this acknowledges some of the more common. This kind of work can't be done in isolation, and I thank everyone for being collaborators. So, and I think we're right at the hour, so I think we can open up some questions.
Okay, we do have some questions. Well, before we close officially, and then we'll have the extended discussion. So here's one. With aging of survivors, what is known about the prevalence and risk for dementia? And perhaps you can define dementia.
Yes.
For our group.
So dementia requires two components. It's a loss of cognitive abilities during adulthood. And so dementia isn't necessarily somebody who doesn't develop cognitive skills appropriately, but it's a decline with age over time in adulthood. And it requires at least two different types of measures. One is memory, and the other is typically often executive function. So we lose some of those skills over time. So we are currently studying aspects of dementia. I mentioned Nick Phillips' study, which will be coming out in the spring, which is going to demonstrate that medulloblastomas survivors demonstrate a larger reduction in memory function over time with age. And this is a change, all these changes being during adulthood. So at a stable point in adulthood, moving forward 10 to 15 years, we see reduction in memory function in medulloblastoma survivors, but also leukemia and Hodgkin lymphoma survivors. As I mentioned, we're still trying to tease apart whether this is due to DNA damage related, similar to what we see in dementia in the general population, or whether it's due to sleep apnea, cardiovascular, or endocrine disease. We have Annalyn Williams and I have a publication under review that demonstrates that not only increased risk for dementia, but that individuals who are exposed early on to neurotoxic therapies may develop cognitive and brain reserve at a lower level, so they may be at a greater risk for a loss of that cognitive function at a faster rate as they age.
Okay, maybe one more and then we'll close officially. Once you improve networks, are benefits sustainable, or do you have to continue to use transcranial direct current stimulation? And there's a similar question saying the other interventions that you presented, what do we know about sustainability of those types of interventions?
We don't know a whole lot, with the exception of some of the physical activity interventions. With transcranial direct current stimulation, what we do is we enhance that neural network and we engage individuals in a cognitive task that utilizes that neural network. So we may enhance the executive attention network and then have them practice executive skills during that enhancement. The enhancement from transcranial direct current stimulation lasts about 90 to 120 minutes. You can demonstrate that through brain image, various types of brain imaging, including magnetic resonance spectroscopy, and then eventually it goes away. Transcranial stimulation by itself may not produce any effects, but what we see it as a way to accelerate the learning that is needed to engage it during a cognitive function. In terms of sleep and some of the other cognitive skills, those are studies that are still ongoing, and we don't know what 9, 12-month outcomes are.
Okay. All right. Well, so we're after the hour, so I'd like to close the official event, but also invite those who are interested to stay on for a continued discussion as we have several more questions posted. Thanks again to Dr. Kroll for an excellent lecture, and thank everybody for coming. Please note that the last in the series on survivorship will be on November 19th, and this talk will be from Dr. Eric Chow of the Fred Hutchinson Cancer Research Center, and the topic will be emerging late effects. And we invite everyone who can, please stay on, and we'll continue with our questioning. Okay, Kevin. Next question is, are there established genetic risks for therapy-related cognitive dysfunction?
It depends on how you define established. Yes, there's data to suggest that there are genetic predispositions for many of the different outcomes. We've published data in the past to show that genetic polymorphisms in the folate pathway can interact with methotrexate exposure to increase the risk of cognitive impairment in leukemia survivors. We've looked at it in terms of radiation exposure, but radiation tends to override, I think, most of the genetic risk factors, at least in the brain. So those are important areas of study that can help minimize the treatment risk. But I think we need to also take into account some of the genetic risks that impact neurodevelopment, and that COMT and an ApoE, which may not be related to the treatment toxicity itself, but may be related to how well the brain has developed and how much reserve or cognitive reserve or brain reserve may be there to buffer against the exposure down the road. These are very important studies to do. They're difficult studies to do because we need large populations who are tested on similar batteries at similar times. Those are studies that are just very, very difficult in single site and even small site collaborations. So there are many studies that have reported some of the risks, and not as many that have validated some of those associations.
So, Kevin, that's actually one of the other questions that have been posted. How do you determine, is it possible to determine the impact of childhood cancer treatment on a survivor's cognitive reserve? So there are ongoing studies doing that, but can you elaborate a little bit more beyond it's difficult to do?
Yeah, so the one study that we did, we looked at, this is one study that Alan Williams has under review. She looked at those individuals who had direct CNS exposure due to their cancer versus those individuals who had indirect CNS exposure or did not have CNS exposure. The individuals who had CNS exposure were impacted, even though those individuals with no CNS exposure tended to have greater frequency of cardiac and pulmonary disease. Those individuals who had CNS exposure were impacted more by the cardiac and pulmonary disease. We interpret that as the fact that the CNS exposure reduced development of brain functions, which is the neural networks and the cortical thickness differences that I demonstrated earlier, and that as that individual then moves into adulthood, they tend to be more vulnerable to some of the other diseases that come along. The difficulty with these studies are that we need 30, 40-year follow-up data. Cognitive reserve doesn't develop overnight. It's the result of all of childhood and continues into adolescence and young adulthood. There are no false studies that follow patients that long, so they tend to be cross-sectional studies and inference-based studies. We do have some work that is beginning at St. Jude looking at animal models that will look at brain aging patterns and look at toxicity associated with that, and may be easier to map out and control some of those exposures to comment on that better in the future.
Okay, Kevin, here's another question. What neuroimaging studies are likely to provide the most insights into the underlying mechanisms of neurocognitive effects of late therapy? And actually, what is the role of neuroimaging in evaluating these folks as a corollary to that?
The role, I'll answer the second question first and then move backward. The role of neuroimaging, in my opinion, is to help, is as a biomarker to help understand the cognitive impairment. In most situations, with the exception of stroke and leukoencephalopathy, the neuroimaging by itself is, without tying it to cognitive function, is not that informative because we don't have good normative data on the neuroimaging. But the neuroimaging helps us to develop associations and understanding, particularly if we can do this over time, to look at white matter disease and how white matter disease may affect cortical growth and development, or the network connectivity that may or may not develop. So the studies that are most informative tend to be from that perspective. As for biomarkers, tend to be diffusion tensor imaging, which can give us a more detailed index of white matter integrity and pathology, and then functional neuroimaging, which can give us an index of the connectivity, functional connectivity in the brain. We can get connectivity with DTI, but just between two related points, point A to point B. With fMRI, we can get connectivity patterns that may involve 5, 6, 7, 8, 9 points in sequence through coherence analysis. So those are two of the MRI components. I think the other that can be informative is the vascular imaging, which can help us understand some of the alterations in blood flow, including arterial spin labeling and potentially functional near-infrared spectroscopy, which can identify changes and patterns of blood flow over time, which may be associated with some of these outcomes as well. So imaging by itself without cognitive function, it tends to not be all that informative, and something I wouldn't recommend as a standard of care, other than identification of tumor relapse or stroke.
Okay, a related imaging study is, might there be utility if you're evaluating dementia and analyzing cerebral amyloid or tau protein accumulations? Has that been done?
Yes, no, it hasn't been done in long-term survivors. It would be helpful to use PET, radioactive labeled PET tracers that can look at amyloid deposition, or mass or magnetic resonance spectroscopy, which can help us identify neurotransmitter patterns and over the brain over time. Those are also difficult and very expensive studies to do, and require a cyclotron and PET imaging facility and the expertise to do that. But those, I think, are worthwhile studies moving forward, particularly in the aging cohort of survivors, to help understand this dementia process that we are beginning to see.
Okay, well, speaking of expense and resource restriction, how do you assess these types of cognitive problems in settings where you don't have a cognitive science, neuroscience lab, or you don't have radiology capacities? What would you suggest to the frontline providers with more limited resources?
Well, I would suggest some of the direct cognitive measures. So the profiles we see show that They tend to be more sensitive. We pick up more individuals with impairment using direct assessment versus self or parent report of assessment. Both are important, but the former seems to be more sensitive. There are some automated computerized systems that can be helpful under those circumstances. There's CogState, which is a computerized assessment battery that's currently being used in COG. There's the NIH Toolbox, which is primarily for research, but assesses cognitive function using a computerized assessment. We also use with our adult and older children CNSDS, which is a web-based assessment that we can do in the homes of the individuals. We've used telehealth procedures. You don't need a 4 or 8 hour battery or even a 2 hour battery to assess those who are at greatest risk. So the approach I recommend is a brief screening, 20-30 minutes, either with telehealth or computerized assessment, or face-to-face testing if you have the resource to look at processing speed, some executive function and attention skills. And if there are difficulties with that, then try to work with the insurance company to get larger batteries done to help for educational planning in the school system.
Okay. Well, I think that is the end of our posted questions. I do want to put in a shout out for the Journal of Clinical Oncology special series that Dr. Kroll and Dr. Christina Hardy are guest editing. And this whole series will be on cancer-related cognitive impairment. And many of the topics that were addressed in Dr. Kroll's lecture today, and many practical issues about evaluating patients, seeking resources within the school system, et cetera, in addition to this sort of cutting edge research and interventions, will be addressed in that special series, which should be published sometime in 2021, likely before June. We're putting it to press now. So be on the lookout for that. That will be a great resource. That is a great summary that will extend this excellent lecture that Dr. Kroll just provided. So thanks again to everyone. Yes, Kevin, your last word.
So just to clarify, that is an issue entirely focused on pediatric cancer. It will, I think, be a good resource. We have an outstanding group of leaders in the field who have put together 12 different manuscripts covering very important areas.
Okay, great. Okay, thank you, Dr. Kroll, and thanks everyone who stayed for this extended discussion. We look forward to your participation in a future series lecture.